Health authorities have tapped local governments to provide breathing space for hospitals overwhelmed by the COVID surge. But will these strategies work in reducing COVID transmission? We discuss in this episode of The Chiefs. Welcome to this midweek edition. Finally, the midweek edition of the Chiefs. With us tonight, Luchi Cruz Valdez, the head of News 5, and joining us in a few minutes will be Robbie Alampay of One News. Hi, Luchi. And I think Robbie's coming online already.
Yeah, good evening.
There
here.
You go.
Present.
Yeah. What's our big story for today?
Well, sa News 5 ay yung nagkakaubusang oxygen tank. Lahat na lang, ano? Oo, talagang
when you think about it, bakal lang yun, di ba? They're just metal cylinders with with valves.
Well, pero makikita mo yung demand for that at home, di ba? Kumbaga, kanya-kanyang bilihan na kasi alam na nga nila na baka hindi sila ma-confine, di ba? Or ma-admit dahil nga sa kakulangan ng bed space. So, yun, nakaka-worry talaga. Makikita mo yung downstream effect, ano? Nung kakulangan sa facilities.
Speaking of downstream facilities, after oxygen, kanina balita rin sa big story, and I think sa News 5 din, hindi lang sa oxygen nagkakaubusan, crematorium services nagkakaubusan. Pila-pila yung mga kinakailangan ng crematorium.
Nasisira kamo. Nasisira yung
bumibigay.
Tawag doon, yung mga makina. No?
Imagine the numbers, 46, we'll talk about Pasay City Crematorium lang. 46 lang yung kanilang clients nung January, naging 63 nung February. It's now at 400 for March. That's almost a tenfold increase from January's numbers.
Grabe, no? Tsaka nakapila yung mga... Nakapila
so, sila ng bagong bumili sila ng bagong makina pang-cremate.
Yung parking lot nila taken up na, 'di ba? By the funeral homes na nakapila yung mga doon, yung mga
ambulansya ron, so yung
mga nagdadala ng katawan doon. Napuno na yung buong parking lot.
Yeah. Ay, grabe.
Other things we're monitoring, of course, everybody's monitoring Malacanang. We have now gotten the announcement. Wala pong address ang president. He didn't address the public on Monday, as we all know. They said sa Wednesday. Now they're saying next week na po. And now that comes also with some concerning news na that's also raising questions na kasi meron daw mga PSG na nag-positive daw for COVID, which then recalls the whole episode about akala ba natin naturukan na yung iba doon?
Baka distilled water lang nga yun, sabi ni
but remember, the vaccines are not supposed to prevent infection. They're supposed to prevent serious or critical infection. They're not supposed to prevent infection.
That's true.
So you could still turn positive even with the vaccines. So there you go.
That's a good point.
Saka nadagdagan na naman yung cabinet member din na nagka-COVID, diba?
Sino bago?
Secretary Lorenzana.
Ay, ako pa yun
Yeah, diba? I mean, kumbaga, dumarami na, diba? I mean, sunod-sunod na rin
tapos
sila.
Tapos may ilang nakaka-strike to na sa kanila, diba?
Oo.
Tapos ibangga mo all these new data with yung numbers today na lumabas. It was pegged at what? I mean, the new cases, it was only pegged at 6,000.
Pero rin daw yun eh. Yeah, pero sabi
diba?
ng
6,440.
delayed din yun. Yeah.
Pero when I was looking at let me pull it up again. When I was looking at the what do you call it? When I was looking at the number of tests done, kasi doon mo siya ibabangga number of tests done versus the number of people who turned out positive. Ang numbers of tests done niya is 37,000 for the day. Tests done.
Yes.
Out of out of that 6,000 ang lumabas. Pero kasi in previous days, kung saan pumapalo tayo ng 8,000 infectees and 9,000 infectees, nasa 20-something thousand lang ang tests. So, hindi siya
kumbaga,
parang ang dami nating tinest, pero ang baba ng new infectees versus yung previous days na mataas ang infectees.
That's the positivity rate in effect.
Yeah, in a way that is eh.
Yeah. Oo. Kaya lang, hindi mo nga masabi. Kasi April 4, ano pa yan tests pa yan di ba? So, ano na ngayon, di ba? April 7 na today. So, hindi mo pa rin masabi kung, yun na nga, kung nag-under-reporting pa ang mga labs. So, yeah. In any case,
plus nga, it's the Tuesday Wednesday effect, you might say. Di ba sabi ni Guido David, pag Tuesdays and Wednesdays historically bumababa
yung numbers sa Tuesday.
Bakit ba? Kasi weekend, coming from the weekend.
Ang daming qualifiers for this week eh. You have the Tuesday Wednesday effect and you have the Holy Week effect.
Yeah.
So medyo magulo yung numbers this week.
Right. Well,
beyond the numbers,
on the better side, yung Sinovac, pwede na ngayon sa seniors, cleaner na nila for seniors. And that's important kasi yung vaccine rollout, di ba? Naubusan na ng AstraZeneca. So, ayun, at least ngayon, sabi ng FDA, at least pwede na magamit for seniors.
For seniors.
Pero yes. Pero ano ba yun? May waiver pa rin ba?
Hindi pa.
Kasi yung dalawang tito sa kabilang programa, nabakunahan na eh.
Talaga.
Si Patrick tsaka si Joby, nabakunahan na sila. They got their first doses today.
Tayo na ba?
LGU?
I think, LGU. Kasi may comorbs sila eh. Hindi sila A2, A3 sila. A2 is senior eh.
Yes.
May mga kilala ko with comorbidities, relatives, and friends as well. Ganon din. May hypertension, that's their comorbidity. And sa Quezon City, their experience was actually pretty good.
Yeah.
So
anyway,
I'm still on the. You go ahead.
At this point, it's good to have high blood pala.
May silver lining. Anyway, Bokang, nandito na yung guest natin, Bok.
Okay. Sige, let's bring in our first guest for tonight. He is Dr. Jose Emmanuel Palo. He is the director of the Medical Cities Acute and Critical Care Institute. Dr. Palo, thank you for joining us and welcome to the show.
Hi, Dr. Palo. Good evening.
Good evening,
Doc.
Batang-bata pa pala si Dr. Palo.
Not that young.
Well, Doc, thank you for joining us. I think it's your first time to guest here. And actually, we invited you for a specific reason. Of course, we do want to talk about a lot of things. Among them, yung nangyayari ngayon sa St. Luke's and I suppose the other private hospitals and your occupancy rates. Pero as well, you came out with a controversial article nung April 1. I'd like to ask you to explain what you mean. Kasi you talked about terrible choices that have to be made, including choices about resources and allocating resources. You talked about it not being right to continue offering advanced care for all, and the need to choose to limit invasive care in favor of comfort care and palliative care. In layman's terms po, what exactly did you want to say?
I wanted to make sure that our people actually started talking about what it meant to them, because they didn't know what someone goes through when they come into ICU. I wrote that article kasi so we're 1 year into the pandemic, and I was thinking to myself, normally I'm very, very proud of the Medical Cities Intensive Care Unit. We're one of the most advanced in the country. We have been beating the odds when it comes to patients surviving their critical illness, except when it came to COVID-19. So I was always wondering what was different. COVID-19 is a novel disease. The world was learning how to treat it. There were resource problems already, even in the beginning. But besides that, we weren't performing very well. And when I spoke to some of my colleagues in other ICUs, and they had the same problems. And in March, the Society of Critical Care Medicine came out with this article from 16 countries, and they had 20,000 patients. They looked up the outcomes, and they were all very bad. So I mentioned that a little bit in the article, and it made me think, if the outcomes of these patients are all very bad, it is probably not right that we keep on pushing intensive care the way that we understand it, which is basically invasive care, being away from their families. And in that situation, especially when there are resource limitations, isn't it more humane also to start talking about alleviating distress, alleviating the symptoms, rather than seeking for cure? It might mean dying, but it might be actually dying without suffering. And therefore, we started talking more about the importance of palliative care, which really is a discipline that talks about that, talks about alleviation of symptoms, and not just the distress of the patient, but also the distress of the family.
Of the family.
Yeah. So it's kind of weird kasi I'm an intensive care doctor. My whole training is about invasive care. And my advocacy now appears to be the complete opposite, which is staying away from intensive care and choosing comfort.
Okay, for the benefit.
Doc, certainly we don't want to take away from the dilemma, di ba? Parang we look at our frontliners as heroes, but at the end of the day, I think one takeaway is that this is all very human. What you're sharing, the dilemma, the pain, the anguish. But I'm just curious, what is the response? What has been the response of your colleagues? What has been the response of your patients and their families? Because I can also understand some people hearing this as, am I hearing a surrender? Am I hearing defeatism? Am I hearing somebody who's defeated? What has been the response of different people?
Yeah, this is actually a very good question, and I wondered about the response after I had submitted the article. The thing is, when we are talking about outcomes in intensive care, we always need to look at the numbers. So unfortunately, I'm going to need to talk about a little bit about the numbers, because that's the reality of things. So when that article came out from the Society of Critical Care Medicine, those 20,000 patients, they were showing stuff like all over the world in 16 countries. There are patients that required mechanical ventilation. That's the one where you have a tube in your throat to help you breathe. Only half of the patients went home, no matter how old you were, or no matter where you were in the world. And then they looked at other factors, and one of them was actually age. And they found stuff like, if you were older than 74 years old and you needed that tube too, only 1 out of 10 patients went home. So it made me think, it's not surrender. We are fighting for all our patients. Remember, even if 50% of patients don't go home, the other 50% did. And it is only through intensive care that you can do that. Those 1 out of 10 senior citizens or older than 75 that made it home could not have done that without intensive care. However, I wasn't sure whether people knew what their chances were going into these kinds of, going into the hospitals, going into the ICU. Did they really know what they were in for? Hence the article.
Just for the benefit of our viewers who may not have read the article, no, let me just take a moment to lift, from your article certain passages or paragraphs, no. You were saying, for example, that as director of acute and critical care and a practicing intensivist, my greatest fear is now true. We will fail our mission to save many of the savable. Okay, now this to me is a crux of the article. You're in effect saying or proposing, if you will, that a decision has to be made as to whether very limited resources, survival resources or equipment be used instead for those who have a better chance at surviving, and instead put those who are likely not to make it in comfort care or palliative care to give them the dignity of, well, dying. That's in effect what you were proposing. My question is, uh, this shifts the burden of decision making on you, the health workers, where before, there was an option for the family to make, which was, for example, do not resuscitate or stuff like this. No, who makes that decision? Are you prepared to make that decision to say, okay, hopeless na siya, wag na lang siya, ito may pag-asa pa? And how do you think families are going to react to such a decision?
So the example will be if there are two patients that are vying for the same resource, let's say a mechanical ventilator, and it's the last one in the hospital. The In the absence of guidance from the hospital or from a higher authority, the individual physician is going to make the choice. And it is going to be a very difficult and terrible choice for that single doctor to do. And that's the reason why we actually convened a group of experts to actually come up with guides for our frontliners in case that ever happened. Now, if it does happen and someone is deemed to be a better candidate for the mechanical ventilator than the second patient, obviously the other patient's family will be disappointed and the patient may likely die. And that is going to be the cost of it. That is going to be basically the whole idea of triage. That is the second half, actually, of that article. Because there are two things. What can we achieve, even at best? And then what can we achieve with limited resources? And there are people that are already waiting or dying outside ERs all over the city. And so we're worried that this will continue. It'll continue. It'll be worse. And then these kinds of choices will need to be made. And therefore, in the presence of the limitations and the outcomes that we can actually achieve, even at best, shouldn't people know? Shouldn't people be offered at least the choice? And then shouldn't we be able to set up our systems in such a way that we can actually help them if they do choose for comfort care or palliative care? So this is what we're working on now.
Doc, so what you're saying is that your dilemma is that in trying to save everybody, you may end up losing many tuloy because of the scarcity of resources, the scarcity of time, and the scarcity of personnel. Pero going back to Luci's question nga po for example, in your case, how do you do this? How do you operationalize what you had in mind? How do you talk to patients? How do you talk to their families?
Right. So the document that we are using is based on some European society guidelines, and it basically is a scoring system. If you had been sick before, you would have a lower priority. If you were relatively healthy and young, then you would have a higher priority. So basically, it's a checklist. And then you compare those two checklists and you see who has the better score. And then you offer the resource to the person with the better score. And then you'll have to communicate with both families, both patients, what had happened. We had never had to do this. So I can't tell you what the reactions have been because we had never had to do it. But it's going to be very difficult. I wouldn't want to be in that position. But
if I may, If I may, I don't know when exactly the article came out, but when you say, this is in a way a new thing, and having to confront this question is on a totally new level, it makes me wonder how contingent is your reflections right now, everything that you're processing, how contingent is it in this current moment when hospitals are getting overwhelmed? I guess another thing is, were you thinking this way 2 months ago or 3 months ago or during Christmas nung pababa yung numbers and it looked like we were headed to better days. How contingent is all of this processing and reflection and recommendations, if they are that, in fact, that, on the current moment of this very dire situation in hospitals?
All right. Well, to tell you the truth, offering the choice of palliative care has been part of my practice ever since. Because we know that a lot of the people that choose to be in intensive care didn't know that there is actually an option to not undergo intensive care. Even learned families, learned patients were surprised to find out that they didn't have to undergo that. So these were usually patients with cancer, usually patients with end stage, let's say lung disease, people that were going to die anyway. So it just became more urgent to actually talk about it and in a bigger sphere. And therefore, because of the looming surge, when I started thinking of writing that article, the surge had only begun. And we were beginning to see more patients requiring ICU being stuck in the emergency room. We didn't have patients, not many patients were being turned away yet. But later on, we had to do that. So, and I was thinking that if our units are full of patients that will likely not make it out of the ICU anyway, then we are not actually going to be admitting patients that we might be able to save. So, and therefore, it became a lot more urgent. And it was a crazy headache and a crazy heartache, actually.
Well, you did say that this was going to be a difficult conversation. And yeah, I can't even begin to imagine how difficult it will be for doctors. Just the other night, we asked about your article to Dr. Limpino. And I remember that her immediate reply was, "We're doctors and we're not to play gods." Just off the cuff, what is your reaction to a reaction like that? That you are not to play gods, that for as long as somebody is still living, that there's hope, and you may not decide on behalf of that dying person.
I agree,
your
Dr.
thoughts?
Limpin, we are not gods, but we need instruments and we need equipment to save lives. So I consider myself a pretty experienced intensive care doctor, but I'm completely useless if I don't have the equipment that I will need to save someone's life. Now, the conversation is difficult, and you did say that it will be very difficult for doctors to have that conversation. But I was not even just talking about that. I was talking about the conversations that we needed to have in families. Long ago, I actually talked to my parents about this because they're getting elderly too. They're getting older, and so they're actually the ones that are at risk for this kind of worsening and intensive care. And we needed to make sure that we were following their wishes, and we needed to know how far they wanted to go. So I'm kind of clear about their wishes not to undergo intensive care. The question is now, did a lot of families talk about it? So that is actually the thing that is more important. The conversations need to start at home. The conversation with the doctor should come later after you have clarified your wishes with your loved ones and with yourself.
Is this a conversation that is, I mean, in that case, on the one hand, it's an example, but at the same time, I think we were all thinking of the same demographic. We were all thinking of our elders in particular. Your recommendations, how much of it is really, in fact, about elderly care?
Well, the only data that I was looking at actually was about elderly care, so I can't really speak about the others. So the only data that we have available to look at is about that, about the older population. It's not an ageist thing. It's just a reality of how this disease attacks.
Okay, how similar or how different would the situation be in, say, a public hospital whose patients are, well, quite obviously in the low income range compared to, say, Medical City, no? How different would their situation be, or similar?
I think that these kinds of decisions are triage decisions are already being done. They're not publicized, obviously, because these are painful things to talk about. But I think it has already happened because they're being swamped,
Mm.
and they're even more under resourced than the private hospitals are.
Doc, I think I don't know if this will come off as empathizing with what you're saying, but I hear what you're saying. At the same time, I think there's a level of me that I don't want to hear what you're saying.
Right.
So maybe just to clarify it, let's role play a little bit. Let's say I come to the hospital, I bring let's say a relative of mine, elderly, let's say mid-80s, mahirap na, on top of that, marami na talaga siyang sakit, severe ang kanyang condition, nahihirapan na siyang huminga, and so on. And I come to you and I say, Doc, ano bang gagawin namin? Pwede bang idiretso yan sa ICU? What do you tell me?
Yeah. So if the patient, I'm assuming already, is going to be heading towards mechanical ventilation, I would be saying that ito po yung i-expect natin. If they go po to the ICU and requires mechanical ventilation, the chances are really that they will not make it out. And I will lay it flat like that. And it's not the same technique that are used by many people. But I think people are sophisticated and mature enough to actually hear the truth and not be... we don't sweeten it. We don't candy coat it. Because it is a disservice, actually, I think, if we don't tell them the flat truth, especially early. So I'll be telling them that, actually, because they need to know what the chances are of coming out of the hospital once they have come in. And then I'm going to say that there is actually an option of not going to the ICU. And if you choose not to go to the ICU, not to undergo the invasive ventilation, not to undergo the invasive lines, the dialysis, all that, we can keep your loved one as comfortable as possible by using special medicines, making sure that they're as comfortable as possible, understanding that they may actually die from this disease during the course.
Now, to be clear, kung si Bok ang dumating at may kasama siyang isa pa ring matanda at yung mas bata ng konti yung pasyente niya, mas malaki yung chance, pero ako pinanindigan ko na hindi, I want my elderly to have as much care as possible, including all the facilities na nauna ako and so on. At what point does the things get out of my control or out of Bok's control and completely in your control?
If we're talking about the last bed in the ICU or the last ventilator in the ICU, then yes, these triage decisions will be necessary now.
And it will be in your hands.
The family?
It will be basically the doctor's decision, but it's going to be informed by a policy, a guideline, a guiding policy that was done at the hospital level.
And the family would have no say on it once that deciding committee makes a decision. Ganun ba yun?
Yun yung magiging Unfortunately, it's going to be like that because both families will want that. Diba? Unfortunately, one family is going to be disappointed.
So you're going to be kind of like the tiebreaker in a situation like that. But
yes.
I imagine that the reason why I asked about the public hospital situation is in a hospital like Medical City, people will presumably have the means to pay, even though it looks like wala nang pag-asa to, di ba? I mean, they will say, wala akong pakialam, just put him there, I want him there. As opposed to a public hospital where, I don't know, will the decision be easier there because, well, people will most likely not have the means to pay anyway. What do you think? What are your thoughts on that?
I think at the time of a severe resource limitation, it doesn't matter whether you can pay or not. If the resource is not there, it cannot be given.
Okay.
Okay.
Wow.
Doc, last question for me, Doc. I suppose you have talked to a lot of your colleagues about this. This is a conversation that you have begun. I mean, I know it is really part of triage. From the very start, it was part of triage, but it's a part of triage that nobody really wants to talk about it. How
Right.
is the conversation going on in the medical community? I know you said it. We have to talk about it among family, but from your end, from your sector, how is it going?
It's very uncomfortable, actually. To tell you the truth, everybody is uncomfortable with it. I myself am uncomfortable talking about this. No one wants to address it, but it's necessary now. So
Mm-mm.
we have to basically work through this pain and basically try to do the best for our patients, the best for our society, without feeling so crazily bad about ourselves at the end of the day.
Okay. One last question, Doc, if you don't mind. The pain, the anguish, the dilemma, everything is clear, and those are with the things that you can control or not control within the hospital. But certainly, you're looking at the rest of our society. You're looking at our government. You're looking at the overall response to COVID. Is there anger as well as part, whether or not that factors into your reflection? But is there anger as well when you look at where we are at this point?
Of course, there's anger, but that's beside the point now. We are at this point in time. This is the situation in our hospitals in Metro Manila. We have to find a solution. And it may not be it's not the best solution. It is the least bad of bad solutions.
Okay.
All right.
Frank conversation with Dr. Jose Emmanuel Palo, Director of the Medical Cities Acute and Critical Care Institute. Dr. Palo, thank you for joining us. And
Thank you.
Thank you.
Maraming salamat.
Thank you. Thank you.
we will just go into a break, so please stay with us.
Welcome back, the Chiefs. We are now in the final stage of our conversation. Now, joining us is Navotas City Mayor Toby Tiangco. Good evening, Mayor.
Good evening.
Good evening. Mayor, hindi ko alam if you are listening in on our first guest, on our first conversation. But let me just say, and I'll say this to you because suki kayo dito. You're practically one of our chief guests. You're practically a chief as well. But I just wanted to start with this because, we've in the course of the Chiefs and talking to people like you, we've talked about disasters, we've talked about a lot of problems, we've talked about corruption, we've talked about problems in government, problems in society. I don't remember a conversation we've ever had in the Chiefs that felt so heavy, at napakabigat. So I just want to ask you, sir, alam ko, we're going to talk to you about the dire situation as well. But is there any good news where we can start off? Is there any silver lining that we can start off with some glass is half full perspective?
Yan, napaisip
Siguro
tuloy.
yung pinakamagandang balita, of course, kulang, pero kahit papano, meron, is yung ayuda. Kulang, pero kahit papano, nagkaroon, di ba? So, yun siguro ang medyo positive na pwedeng sabihin sa ating mga kababayan?
What about
Aside from that, honestly, yung bakuna, unti-unting nadadagdagan. Today, supposedly, though hindi pa official, yung Sinovac has been approved already to be used by the FDA and the DOH for senior citizens. So yun, siguro, kung maging maayos yun, that's good news.
What about
Yun
po itong
siguro.
usapin na, of course, ang isang malaking problema natin this past days is hospitals becoming full. Now, where we have you as our guest precisely because ang usapin ngayon is maybe the LGUs can help in the triage system at the level of the communities to decongest our hospitals. What is your perspective on that? Is it hopeful? Is it pragmatic? Do you think LGUs can make a difference here?
Wait, nawala lang yung volume ko. Hello?
Yes, sir. We
Hello.
can hear you.
Papa,
Yan.
can you hear us now? Can you hear us now?
Okay, can you repeat?
Papa, ulitin ko lang pa. What about po itong usapin na LGUs can help in decongesting our hospitals by tweaking our triage system, bringing it down to the level of the communities, to the level of the LGUs? Are you hopeful with that? Are you pragmatic? What's your perspective on this whole thing of let's develop a system where the triage goes all the way down to the LGUs and maybe we can find a way to decongest our hospitals that way?
So actually, we're on the process already. It's an ongoing process in Navotas. Noong linggo, dumating si Director Balboa doon sa Navotas and si the Assistant Regional Director Pascorales of the DOH. Meron kasi kami doon dati na isang isolation facility, no? Na ginawa naming vaccination center kasi kala namin dadami talaga yung bakuna. And then nung nagka-surge, binabalik na namin siyang isolation facility and nakita nila ideal for triage, no? So yun, they will send us the additional equipment. We just have to man it. So within 2 weeks, we will be ready. 100
Nako,
beds
we
yun.
just yung sentence na we just have to man it. Actually, yun nga raw ang problema, no? Do you have enough people to man it? I mean, kasi kulang-kulang din ng health workers, di ba? Even in hospital, sabi nga ni Dr. Almora, it's not so much the capacity but the capability as well. So, yun ang tanong ko sa'yo. Do you have enough to man it?
This one, I was given the assurance by our City Health Office, kaya namin iman tong 100 na to. Kasi magdadagdag nila kami ng doctors dito eh. Yung nurses, if we were to operate it as a community isolation facility, we would have had the nurses already, di ba? Nandiyan na yung nurses. So yung doctor na lang ang kailangan, tsaka yung equipment na manggagaling sa DOH. Kailangan lang talaga madaliin natin. No? The thing here is, limitado ang capacity, limitado ang tao, at ang oras natin limitado. Lahat tayo, we only have 24 hours. Pero padami yung inaasikaso natin. For example, local government take care of food, relief pack, ayuda, and all these other things that are coming up na dapat sabay-sabay, di ba? So, yun ang medyo challenging talaga. But we just have to face it. We just have to try our best. Ganon. So, ang ginagawa namin sa Navotas, hinto muna yung tax payments. So, para yung mga tao doon sa collection side, nagagamit naman natin sila sa disbursement side ng pag-distribute ng ayuda na cash. Tapos yung iba sa ibang mga department, pinapatulong naman natin sila pag-distribute ng ayuda na pagkain. Ganon, no? Pero syempre, pag professional, pag nurse, at pag doktor, hindi naman namin pwede ilagay doon yung ibang mga empleyado ng City Hall. Pero ganon ang ginagawa natin. So talaga, may mga services na bababa, katulad ngayon tax collection, ang parang stop muna, ganun muna ginagawa namin para ma-maximize lang yung mga tao natin. No? And it's not only yung health services talagang lahat ng serbisyo apektado, mga tanod, nagpa-positive, madami, lahat talaga na-apektuhan.
Sir, we're not just talking about the quarantine or isolation facilities. We're also talking about triaging in general. Kasi yung sasabi ng DOH, sa inyo na ipapasa yung triage system. Ibig sabihin, kayo raw po, yung mga LGUs ang hihimay kung sino sa mga lalapit yung dapat pumunta sa ospital, sino sa mga lalapit ang dapat pumunta sa mga quarantine facilities or isolation centers. In other words, parang one-stop shop po kayo kung kayo magpa-farm out kung sino pupunta saan. Hindi na pwedeng dumiretso o rumekta yung pasyente sa ospital. We're wondering po how that is going or how that is going to go. Ano yung proseso?
Yun na nga, napag-usapan namin yun na I think that was Monday night, no? Ganun nga. So first, we have to prepare the facility. So yung facility, prepare natin. But again, the biggest challenge there is how to convince people. Kasi hindi naman natin mapigilan yung tao, di ba? Kahit sabihin may triage dyan, mas komportable sila pag nasa ospital eh. So it is giving them the assurance na they will be taken care of dito sa triage, na kung lumala, huwag naman sana, madadala sila malilipat namin sila sa ospital. Yun yung yun yung challenge talaga dyan eh. Yung kung alam nilang may triage system, na magpunta muna doon sa LGU. Paano kung ang gawin na dumirekta sa ospital? Paano gagawin natin doon?
Well, yun nga ang
Actually, yes, sir.
pinipigilan daw nitong triage. So, kumbaga, dapat daw sa LGU na
kayo unang pasada, kumbaga.
i-decide kung anong magiging, sabihin na natin, kung anong magiging filtering process nyo, di ba? Na paano nyo sasabihin na kung gusto nyong magpatingin, wag muna kayo dumiretso sa ospital, dito muna kayo. Meron ba kayong ganong sistema? I also wanna imagine kasi, paano ba ino-operationalize yung triage system, di ba? Kunyari ako, nakaramdam ako, saan ba ako pupunta? Hindi ko rin alam. Paano po ba yan? How does it really work on the ground?
Magbabantay ba kayo sa ospital na parang hindi pwedeng dumiretso sa ospital, ha? May magbabantay ba sa ospital? Kailangan duman muna kayo sa triage, gano'n ho.
Hindi, yun nga eh. Assuming nandyan yung facility, di ba? So, sasabihin natin, for example, there are two cases. Yung isa, yung hindi sa amin nagpa-test. Nagpa-test sa private laboratory or sa ospital. Tapos ayaw yung dumaan sa triage. Paano namin siya pipigilan? Mas mauna malaman niya na may COVID siya. Okay, number 1 case yun. Number 2, assuming kami na yung may alam. Dahil sa amin nagpa-test. Pinuntahan yung pasyente, dito ko muna sa triage. Nag-insist siya na gusto niya sa ospital. I don't think we have that authority to stop him from going to the hospital. I think that is his right. Ang hindi niya right is to stay at home. Kasi kung may facility, hindi kami pumapayag in general na home quarantine. But if he says that he wants to go to the hospital and ayaw nila sa triage, I don't think that there is any law that we can use to stop him.
Mayor, it makes me curious. And I think kasi sinasabi ng DOH, mag-uumpisa na this week. Sinabi ng DOH, nag-usap na kami ng LGUs. Ito na ang bagong system. I just wanna understand.
Cutting the line, cutting the direct line to the hospital nga daw eh.
No, but I just wanna be clear. Pinag-usapan ba ito? Paano pinag-usapan? What exactly did you resolve with the DOH?
Robbie, ang pinag-usapan doon is maghanda kami. But again, the challenge namin naman, ang hindi na-resolve doon is how do we convince? So they were saying you have to, parang it's yun yung hindi natapos pag-usapan kung paano makukumbinsi. Of course, may mga strategy silang sinabi. You have to assure them na kung lalala sila, madadala sila sa ospital. Yun ang hindi talaga na-resolve. Ang na-resolve lang doon is yung physical arrangement, yung pagtayo, yung pagman. Yan, na-solve yan. Ang hindi talaga na-solve is paano mo pipigilan. Because you cannot stop anyone from going to the hospital. That is his right. Diba? So parang yun na nga, communication strategy, how do we communicate to them, yan yung talagang hindi pa na-solve up to this point.
Pero Mayor, can the hospitals refuse to admit, if they're public hospitals, can they refuse to admit patients until they have gone through the triage? At least for public hospitals.
For public hospitals, I think it is the decision of the medical health officer kung sa triage siya o doon siya sa hospital. I think kung public hospital, no? Because i-examine naman siya eh. Siyempre, sabihin ganito. Pero sa amin, hindi namin magiging problema yan kasi puno na yung hospital namin eh. So kahit gusto niya dun sa ospital, hindi talaga namin ma-accommodate eh. But again, that is a gray area because alam mo, iniisip-isip ko, what law can you cite telling a person na you don't want to accommodate him sa hospital?
Kaya nga po, we asked kasi in other words, parang persuasive lang ang declaration ng DOH earlier this week na there's a triage system. It's just persuasive. They're just convincing people. You go to the triage, but we cannot force you to go triage.
I honestly think you cannot force anyone to go to the triage, no? For example, yes, go ahead.
No. Yeah, you were going to make an example. Go ahead, Mayor.
No, I was saying, for example, Navotas City Hospital, no? Kung puno, pwede mo siguro sabihin dun sa tao, wala na talagang kami pagdadalan sa'yo. Nandun ka muna sa triage, no? Pero kung bakante at may bed, I don't think we can refuse.
Yes.
Kung may sakit talaga yung tao.
Yes. Right.
Kung COVID positive siya, no?
Actually, we agree with you because we have these same questions in our heads, no? Na parang, even if you have a triage system, can you really honestly tell people, dito ka muna? Diba? I mean, malabo talaga yon. So my question to you is, knowing that the hospitals continue to be filled with patients, no? Does it look to you like we're ready for MECQ next week? I mean, how is the situation in your city? Would you recommend it in the Metro Manila Council?
Alam mo, Lucy, what people have to realize is the longer it takes, the more and more difficult it is. No? Either way you go, it's between the devil and the deep, Lucy. Either way you go, may problema. Extend mo yung ECQ, may problema. Wag mo extend, may problema din. Diba? So, it becomes more and more difficult now. Ibig sabihin, kung noong una mahirap magdesisyon, yung pag-extend o pagbukas, mas mahirap pa yan. Pag tumagal ng pagtumagal, pahirap yan because dumadami, assuming hindi natin mapababa, no? Dumadami yung cases, tapos yung tao, mas humihirap yung buhay. So pahirap yan hanggat di natin napapababa yung kaso. Kaya nga, ang lagi kong pakiusap is, huwag natin sayangin yung panahon, huwag natin sayangin yung bawat isang araw na mapababa natin yung kaso. At ang paraan dyan is siguraduhin mo na ikaw mismo ay hindi mahawaan. Pag ang bawat tao, masigurado niya na hindi siya mahawaan, mapapababa natin yung kaso. Pero pag hindi ganyan, habang tumatagal yung panahon, ang hirap. Pag hindi, let's say, tuloy-tuloy yung kaso o hindi bumaba, ano gagawin natin? Mag-ECQ pa tayo, problema, hirap yung tao. Kung hindi tayo mag-ECQ, lalong tataas yung kaso. So, ang hirap na desisyon yan. Sobrang hirap na desisyon yan.
So, I think pati naman kami walang sagot. No? Pero let me emphasize a point. Basically, you're saying na to be perfectly honest, it's a hard decision, obviously. But what are you waiting for? Other than na bumaba ang numbers, is there anything else objective and tangible that you're waiting for to make the decision a little clearer?
Hindi, yun na nga. Itong triage, okay, yung triage, para mas maintindihan natin is, kasi kung ang sitwasyon naman natin, if we have, okay, even if tumaas yung kaso, but if we have enough hospital beds para ipasok yung mga may sakit, hindi kailangan mag-ECQ, di ba? Agree tayo doon, di ba?
Critical care kasi yung isang component. Yes.
Hanggat may mapagdadalan sa mga may sakit, hindi natin kailangan mag-ECQ. Ang dahilan kung bakit ECQ tayo is kasi wala na tayong mapagdalan. So ang reason ng pag-triage is parang dinadagdagan natin yung hospital beds natin. Ngayon, ang ano na lang dito, ang challenge is kumbinsihin yung tao na gamitin yung triage. Kasi yung number of beds sa triage is actually number of beds for hospitalization. Kaya lang, wala lang nga sila doon sa hospital. So yun nga yung ginagawa ng DOH. para maiwasan siguro yung pag-extend ng ECQ.
So sa tingin niyo po ba nga, assuming na mag-work yung triage system at well, ma-persuade niyo mga tao na doon na lang muna and there's enough, you think that you'll be ready for an MECQ?
Let's see, no? Let's see. Ngayon, alam mo, ngayon ko na naisip, ang sa tingin ko mangyayari dyan, pupunta sila sa ospital. Pag siguro isang araw, hindi pa sila makapasok sa ospital, baka makumbinsi na silang pumunta sa triage. Pag 1 week, 2 weeks, okay naman yung triage, makukumbinsi na rin yung tao na doon na muna pumunta sa triage. Sa tingin ko, ganun yung mangyayari dyan.
Bakit kayo merong Q-band? Why do you need to track the positives? I mean, can you tell us about that? Na-intriga ako doon yung may
Okay.
Q-band.
Ito, alam mo, Lucy, tinano namin to towards the end of February pa. The reason bumili kami ng Q-band noong end ng February is nakita namin tumataas yung cases unti-unti. But honestly, we did not expect it to be this much. Kasi nung beginning of February, nung mabababa yung kaso namin, 33 cases kami February 7. Gusto namin talaga isagad na. Sabi nga namin, pwede isira natin. So ang ginawa natin, pag contact trace pa lang, habang nag-iintay ka na resulta, dinadala na namin sa isolation facility. So you're isolated once naging close contact ka. And you get to go home lang kapag ikaw ay nagkaroon ng negative RT-PCR. Okay? And nung tumataas na yung kaso, hindi na namin ma-isolate yung mga close contacts. Kasi kulang na yung isolation facility namin. So napilitan ulit na yung mga close contact sa bahay. So kaya namin to binili yung Q-band para yung close contact habang nag-iintay siya ng resulta niya, hindi siya pwede lumabas ng bahay kasi may Q-band siya.
I see.
Parang
So, hindi nyo yung magamit ngayon. So, hindi nyo yung magamit ngayon. Sobrang dami, di ba? I mean,
Okay, so yun. So may QR code yan. You have to scan it twice a day. Pag tinext ka, iscan mo, alam namin na naka-geofence ka, hindi ka lumagpas ng 15 meters from your place of home. Okay? So alam namin na doon ka. Pag lumabas ka, i-report ka, bakit may Q-band lumabas? Ngayon, buti na lang naka-order kami noon. Pero paubos na rin kasi hindi na nga namin in-expect ganitong kadami. Kaya kung may supplier dyan ng ban na hindi pwede paliguan, na pwede pinta ng QR code, please contact the Navotas City Government. Kailangan po namin yan. So ang nangyayari ngayon, dahil hindi na nga magkasya sa isolation facility, wala nang paglagyan, yung mga nag-home quarantine at yung lockdown areas, lahat yun naka-Q-ban. Naka-quarantine ban.
Okay.
So, hindi sila makalabas ngayon. Kasi imagine, yung home quarantine actually na sinasabi is also a good idea. But how do you manage it? If you have 100, 200 houses na naka-home quarantine, sino magbabantay dun? Diba? Ito, napapantay namin because of the Q-ban. Pag lumabas ka, susumbong ka ng tao kasi hindi ka dapat lumabas. Tapos hindi mo naman alam kung ano ang text. At pag nag-text lang, sumagot. Tapos, yes, go ahead.
Mayor Marino naman that in everything, I mean, from the very start, people are saying LGUs napakahalaga, if not the most important, whether it's contact tracing, whether it's lockdown, whether it's innovating on things like this, and now triage, and ayuda, lahat, frontline talaga ang LGUs. But I'm just curious because a lot of people now are saying, ang complaint namin is what's the national strategy? We haven't seen President Duterte for a number of days. We now get official word we will not see him for at least another week. On the national strategy level, nabibitin ba kayo or are we getting clear enough signals and direction from the IATF?
And yung meetings namin with the IATF tuloy yan. Monday evening, we met from 6 p.m. to 11 p.m. 5-hour meeting yun with the Metro Manila mayors and the IATF. Ang daming napag-usapan doon. Tuloy-tuloy naman. At least twice a week. The past 3 weeks, we meet at least twice a week. So, although we don't participate in the IATF meetings, si Secretary Vince Dizon, Secretary Charlie Galvez, Secretary Lorenzana, Secretary Duque, kamiting namin. Si Yusek Florese, kamiting namin on Monday. And they always meet with us. And we're in constant communications through Viber, So ganun. Okay naman yung communications namin sa kanila.
So how would you evaluate government performance? I mean, at this point, can you think of things that government could have done better or sooner that it didn't?
Naku, mahirap yan, Luchi, because when you say government, I'm part of government. I'm part of implementing it. So grading the performance is like grading myself, di ba? So,
So ganito na lang, Mayor, para forward looking, and we won't ask you to grade government. But as you said, nagmi-meeting naman kami ng IATF. And I don't know if we're just missing the forest for the trees, di ba? But how would you summarize it? What is the strategy? So if you're saying, okay naman, malinaw naman yung direction sa amin, malinaw naman yung coordination namin. But what people are asking is there a strategy? How would you summarize it in 2 or 3 lines? What is the strategy of government?
Hey, the strategy talaga is to get the population vaccinated because we've seen this naman eh. The problem there, the challenge there is really the availability of vaccines. Yun talaga, di ba? Hindi nasunod yung plano natin doon sa delivery ng bakuna. Pero syempre, I've seen it, talagang si Secretary Galvez is really trying his best. Kaya lang, ang hirap eh. And we experience it also, no? Katulad, di ba, pumirma yung mga LGU ng January 10 ng AstraZeneca, kailan pa delivery noon? July, di ba? Okay, ngayon doon sa challenge. I think the biggest challenge I can speak for myself, no, sa LGU. I think the biggest challenge really, I will be very straightforward, was the communications, no, the different messaging. If you will recall, every time you talk to me, I always say, I'm worried. I always say, lumabas lang pag essential. Wag lumabas kung hindi kinakailangan. Pero iba yung messaging dati ng gobyerno, di ba? Ang sinasabi, hindi, lumabas kayo, buhayin yung ekonomiya, bumisita kayo dito, pumunta kayo dyan. Di ba, may time pa nga, gustong buksan yung movie house, gustong palabasin yung mga bata. Doon talaga, that was the real challenge for me. Kasi iba yung sinasabi ko, iba naman yung sinasabi ng national government. So doon talaga, I have to be very open na talagang yun talaga, nahirapan talaga ako. And at many times, hindi talaga kami tumato.
Okay. Navotas Mayor Toby Tiangco. Sir, maraming salamat for joining us tonight. So, ingat po.
Thank you,
Salamat,
Mayor.
Thank you. Stay safe. Don't get tired.
All right.
Okay, that will be all for this Wednesday edition of The Chiefs. We hope what is discussed here will keep the conversation going. Remember po, mask on, wash hands, and stay safe, Philippines. I'm Ed Lingao.
I'm Lucy Cruz Valdez of News 5.
I'm Robbie Alampay, and we are One News.